to this webinar titled Collaboration Lab Number 2, Partnering with Families, Communities, and Local Health Departments. My name is Becky Goins, and I am the Programs Associate on the Health Systems Transformations team at AMCHIP. On our agenda today, we will start with Welcome and Housekeeping. Paige Bucinich, the Senior Program Manager for Children and Youth with Special Healthcare Needs at AMCHIP, will make opening remarks. She will then introduce the speakers and turn it over for their presentations. There will be time for a Q&A throughout. Lastly, we will wrap up this webinar, and a short survey for you to complete will open up on your browser. So before we begin our presentations, I just want to run through these housekeeping reminders. So everyone's lines are muted, except for the speakers and me, of course. And if you want to unmute your line, though, just press *6, and you can ask a question and adjust the volume on your computers. If you're having any technical difficulties with your audio, just use the chat feature on the right, and I will be able to help you. Looks like some people are already using it, which is great. If you need to step away from the phone, please do not put the call on hold, or we will hear the awkward hold music. So just hang up and join again. Submit questions or comments in the chat box, as I mentioned, which is at the lower right-hand side of your screen. And as I've already said, today's call is recorded, and the recording and slides will be available on the AMCHIP website within a week or less after this broadcast. And finally, as I mentioned earlier as well, there will be a short evaluation survey that will pop up automatically after the webinar has ended. So please take a few moments to provide some feedback. We really, really appreciate your input, and it's very helpful when we plan future events and learning opportunities such as this. So now I would like to turn it over to Paige Bucinich, the Senior Program Manager, for the welcome.
Wonderful. Thanks so much, Becky. We're very excited about this national webinar, which is part of AMCHIP's ongoing work to equip maternal and child health programs and partners with effective strategies and proven practices for collaborating. Today's conversation is part 2 of a 3-part series that is exploring these strategies. The first webinar in the series took place about a month ago in November, and this webinar focused on increasing knowledge of the evolution of recommendations regarding the provision of direct services by public health agencies. Our distinguished panel of Title V Children and Youth with Special Health Care Needs directors provided examples of effective population-based services and collaborations. We hope that with today's webinar adding to the series, you will continue to find the series useful as the ideas and concepts presented come directly from the practices of our guest speakers. Today we're really excited to shift the conversation towards change management strategies for maternal and child health programs to enact as they embark on initiating and sustaining partnerships and collaborations with diverse stakeholders. We will hear from an illustrious panel of partner organizations that work with local health departments, community health workers, and families. The objectives for today's webinar are to increase knowledge of initiating and sustaining partnerships and collaborations with stakeholders at multiple levels, with special emphasis on families, communities, and local health departments. Identify effective strategies and best practices for partnering with diverse stakeholder groups, and equip participants with the skills for measuring the success of collaborations with diverse stakeholder groups. The MCH leadership competencies that will be addressed today are critical thinking, interdisciplinary and interprofessional team building, and family professional partnerships. Now, before I turn it over to our speakers, I would just like to give a brief introduction to all of our speakers. You can find out more information about their roles at their respective organizations by downloading the Webinar 2 Agenda and Bios document that is in the file pod, which is the second box on the right-hand side. As Becky mentioned, during the presentations, please feel free to submit your questions via the chat box, and we'll be sure to address them during the question and answer portion. Our first speaker today will be Karen Schrieweiler, who is the founding partner of Total Population Health. Today, Karen will provide an overview of change management strategies for Title V maternal and child health programs as they embark on initiating and sustaining partnerships and collaborations with stakeholders. Next, we have Kara Foster, who is the Education and Training Manager at CityMatch. Today, Kara will give the local health department perspective on partnership with Title V maternal and child health programs with an emphasis on strategies to encourage meaningful collaboration. Then we will have Abby Charles, who is the Senior Program Manager at the Institute for Public Health Innovation. Today, Abby will give the community systems perspective on partnership with Title V maternal and child health programs with an emphasis on strategies to encourage meaningful collaboration with community health workers. Then we have Donna Yodrich, who is a part of the Family Advisory Council with the Kansas Special Health Services and the Maternal and Child Health Title V program. Today, Donna will provide an overview of broad approaches to family engagement beyond just children and youth with special health care needs engagement. Donna's presentation will be framed by AMCHIP's 4 levels of family engagement in Title V maternal and child health and children and youth with special health care needs programs. Then finally, after all of our presentations, we have a special guest. We have Stephen Orton he's the Senior Fellow for Public Health Leadership at the North Carolina Institute for Public Health, as well as the Adjunct Assistant Professor of Health Policy and Management Department at the UNC Gilling School of Public Health, Core Lead of the Change Management Core at the National MCH Workforce Development Center. So you'll get to see Steve's picture a little bit later. He's not on this slide, but Steve is going to lead us in a great closing activity that'll lead us with, it will leave us with some action steps as we leave the webinar today. So without further ado, I will go ahead and turn it over to Ms. Karen Schrieweiler.
Well, great. Thanks so much, Paige. I appreciate it. And good morning or good afternoon, everyone, depending upon your time zone. It's my pleasure to join you today to set the stage for this conversation around collaboration and partnerships. My background is primarily in working at the state level, and my 25-plus years of work in Colorado's MCH Title V program has primarily revolved around state partnerships and collaboration and lots of work with local health agencies. So I'm glad to see Karen and CityMatch on this discussion today as well, since they are such key partners, among others. So as we sort of get this series rolling, and yay, I got my slide up. That was my worst fear, so now I'm just going to be totally relaxed. I think that in setting the stage, the one word which really came to mind for me was how important clarity is to the process of collaborations and partnerships. As you all know, we use collaboration and partnering as a means of improving maternal and child health. So it's definitely, I think, one of our main strategies. And in order to do so well, it's important that we're clear about both our intent and then what we hope to achieve with our partners. So that involves us as conveners or organizers in our various organizations, understanding our purpose. And then we also need to be able to communicate that purpose clearly to our partners. So with that being said, I'm going to move forward and discuss some key elements in providing clarity around collaboration and partnerships. So as you can see from this first slide, establishing clarity involves a number of considerations. And both thinking about strategic considerations and having a clear, well-stated purpose kind of happen simultaneously. I am going to start out with a clear, well-stated purpose and then kind of move back up to talk more about strategic considerations. So I think, again, clarity is key, and understanding your purpose really provides the clarity about the effort that we sort of have on the table. What is it that we want our partners to do? What do we want to achieve? How are we going to know if we've done it? And then who is needed to partner? So having a clear purpose around the effort helps us clarify what partners we might want to reach out to or convene to work with us, to collaborate. And in putting that on the table, I'm also going to sort of make a plea for less is more. I think when you're thinking about these efforts, think about who your key partners are. It doesn't need to be multiple people from the same organization unless that makes sense. And you really want to be thinking about those folks who have the content expertise, who may have some decision-making authority or ability to commit their agency or organizations to work with you, or better yet, to provide some funding. And then, some of the history involved in previous collaborations. How well have those gone in the past? Again, you want to be communicating the what and the why clearly to your partners, and you want to re-communicate that purpose at every meeting so people stay clear. Now, some of us have probably been involved, and I know when I worked at the state, I was involved in a number of meetings that were sort of like the regular monthly meeting of everybody that was doing children's programs, where people from multiple agencies would come together and everyone would update on what they are doing. Again, I would say that there's certainly nothing wrong with having conversations and updates, but again, it needs to be purposeful and intentional so people really understand what it is they're coming to do and what the benefits are for both partners. Also, and again, we're going to talk more in a few minutes. Kara's going to talk about local health agency partnerships. But the other thing to keep in mind relative to your purpose is when you're working with local health agencies, sometimes if you're a state representative, we have contractual arrangements with local public health to work with us. So in that case, you're you have a dual role. You're a contract monitor, but you're also a partner. And sometimes those two roles can cause some confusion or tension. So it's important to be clear on the front end about what it involves to work sort of in both arenas, if that makes sense. Okay, moving on. Let's talk about strategic considerations. So again, as we talked about around sort of having a clear, well-stated purpose, strategically we want to be thinking, what's in it for others? How does our need also meet their need or benefit them? And then how would they view or define success? This notion about going to their table versus always asking people to come to our table. And this is particularly, I think, key when you're working with regional agencies or local health agencies. There's a lot to be learned when you go out and learn about local communities, learn about their history, their culture, their values and attitudes, and how can you respect those and maximize them in your process. So meeting people on their turf and understanding where they're coming from is very important and key. You can really maximize your effort. It's also valuable to get to know people before you ask them to do something for you. It's much easier to collaborate with people you know or have experience with. And if you've done successful projects in the past, it's very easy to contact people and bring them back into the fold, particularly if those efforts have been successful. But the importance of building relationships with your partners before you ask them to do things for you, I think cannot be understated. And sometimes I think we kind of forget about the importance of relationship building in this process. The last thing I'll say about strategic considerations, and sometimes I think we fail to think about this, is that be mindful that where people choose to spend their time is also a financial decision. So sometimes people either don't have the bandwidth or it's not a good use of their time to participate in an effort. And I think, that we need to think a little bit more about, how people's time translates into dollars. And is this effort a place where we actually want to invest people's time and then, their salary or their finances? So we also need to be thinking about making a case for investment. And then it also gets back to sort of my earlier point, less is more. If you're sending 6 people to the same meeting and you cost out their salary, that's a significant financial investment, and it may be worth it. But on the other hand, be cognizant of the fact that, collaboration also involves finances. And if this notion about sort of resource management, sort of people and finances is of interest to you, I'm going to do a shameless plug for the upcoming AMCHIP conference. Dorothy Salenti and I will be doing a presentation on managing resources to move the needle for MCH impact during the skills building session. So we'd love to see you at that session as well. All right, moving down our little bulleted list, the next element is expectations, roles, and responsibilities. And again, all going back to clarity, we want to be clear and detailed about what we're asking our partners to do, the when, the where, and for how long. And then whatever expectations we put out on the table, it's very helpful if we stick to those expectations. We want to, again, understand what partners bring, what they want and need. We want to understand what we're bringing. What's our capacity? And then general readiness and capacity. Are people able to participate? And this gets down a little bit to timing as well. Knowing your partners is very helpful, and what kind of time commitments they may or may not be able to make. And certainly at the state level, if you avoid certain times of the year, the legislative session, or many states are having gubernatorial transitions, those times are very key for state staff, so be cognizant about other things that might be on the table that could impact their readiness. Keep in mind that partners discontinue or disengage when they feel the efforts are unrealistic or unfocused. Okay, this last slide, some other considerations. You want to have a functional structure. You want to develop a functional governance structure for the effort. Somebody needs to be in charge, and a clear structure ensures accountability for everybody that's going to be involved. Again, as we talked about before under expectations, whatever it is that you put on the table, that was the purpose and the charge of the group, respect that and honor the gift of people's time in working with you. Systematic implementation is also key. You want to make sure that you're doing what you said you'd do. Keep the process moving as outlined. Develop a decision-making process and get buy-in on the front end, and then utilize it as you agreed to keep the work moving forward. And then you want to track and communicate your progress to the group. And this is particularly important with long-term projects. You want to identify some intermediate benchmarks so that people can see that you're moving forward, that the effort that they're putting in is beneficial. Again, I think this whole notion of doing what you said you'd do and don't ignore the end point. If you get to the point at which you thought the project would be over and it's not, then definitely talk to people about an extension and get some agreement to keep the effort going. And again, I think the importance of that consideration is that it builds trust for the future, that you won't draw folks into vague efforts without clear outcomes and endpoints. And then you want to celebrate your successes and accomplishments and highlight the contributions of each partner. Again, I think this builds trust and it sets the stage for future collaborations. So in wrapping up this intro, I think, again, just to reiterate, that collaborations and partnerships are just a key strategy of almost all the work that we do in MCH. And we absolutely need this power of the collective brain, I always call it, to achieve an outcome. Keeping in mind that collaboration and partnerships themselves aren't the outcome, they are the strategy that we are going to employ so that we can have, the best impact on the health status of the maternal and child health population. And our processes need to be clear and intentional. So with that, I am going to wrap up this intro, and I'll certainly be on the line if other people have any questions or comments. And I know some of these points will be echoed by my fellow presenters because I've seen their slides as well. Thanks so much for joining and for your attention.
Wonderful. Thank you so much, Karen. That was a really great intro. So we'd like to open it up for any quick questions that you may have for Karen before we dive into some more, a deep dive of examples. So we'll pause now for a minute or so to let folks either type their questions into the chat box, or you are more than welcome to unmute your line by pressing *6 to ask a question. Don't be shy. We love hearing people's voices here. So. All right, well, I'm assuming there's no takers, and that's okay. Maybe you'll have some other burning questions that will arise as we continue through our presentations. So now we will begin our panel of Partnerships Beyond Title V with Kara Foster from CityMatch. And just as a reminder, you can submit questions in the chat box throughout everyone's presentations, and we'll be sure to address those questions to them directly when we have a chance. So with that, I'll turn it over to Kara.
Thank you. So my name is Kara Foster, and I'm the Education and Training Manager at CityMatch. And if you're not familiar with CityMatch, CityMatch is a membership organization for local urban maternal and child health departments. We have about 170 members, member health departments across the country, and then hundreds of associate members as well. And in my previous role at CityMatch, I worked with dozens of health departments, most recently with the Collective Impact Learning Collaborative, in which we foster state and local alignment around MCH priorities. So I'll be sharing lots of examples directly from that project. Both states and locals can benefit from building relationships and understanding what's happening and how things function at each level. So some reasons to partner include improving communication, building relationships, increasing awareness of programs, services, and barriers at each level. And when I say each level, I mean state and local. Working closely with local health departments as you develop your 5-year needs assessments. And also, local health departments can assist with opportunities to connect states with community beyond families with special health care needs. We know that that's an area that many states are doing well in, but there are lots of other families out there, and health departments can be a connection. Some potential outcomes of partnering include improved health outcomes for communities, increased utilization of services, more efficient systems and processes, and of course better alignment with locals could help states meet or improve Title V priorities, NPMs and SPMs. So what makes a great local partnership? As Karen mentioned, regular communication is key to building these relationships. This can include locals reporting on the work that they're doing at the local level. It could also include states communicating ways that locals could contribute to impacting national performance measures, etc. Some other hallmarks of great partnerships would include working toward the same goals and priorities, involvement at the local level, meaning like if there's a local coalition, having someone representing the state be involved at the local level. Offering state services such as training, technical assistance to local health department partners. Acknowledgement of each role. Responsiveness and accessibility. And of course, these should be mutualistic relationships. And I think you'll notice that I really enjoy analogies from nature throughout my slides. So before I share some examples of thriving partnerships, I just want to preface this by saying that I know each state is unique, and for some, local health departments actually are at the state level. I know that many in the southeast states and others have decentralized systems. So take it with a grain of salt because every state's a little bit different. So the first example is from South Carolina. And in South Carolina, there's a statewide child well-being coalition. Some things that make it a thriving partnership include the Title V director is directly involved on the core leadership and planning team of this coalition. And within the coalition, there's a unique, dedicated state epidemiologist for each of the 5 subgroups of the coalition. So I believe they have subgroups like health, education, and other things, and each group has an epidemiologist from the state level dedicated to being a connection between the data and the work. They also have shared decision-making and ownership, and they have broad representation from other non-health sectors and community members. And the second example is from Colorado, where there's a pregnancy-related depression coalition in Fort Collins. And in Fort Collins, they're working from a state work plan with a menu of options, and the locals get some input and some creativity to determine which areas they want to work on and how they want that to look. The state has offered many resources to the local coalition, including some media campaign materials, and they also, the local health department and the coalition has some freedom of creativity with their work. So they can use the state's media campaign materials, or they can create their own. And the state can support them in other ways. In this coalition, there's regular communication between the state and the local level. So in Rhode Island, the state health department has served as the backbone for some state-led local health equity zones. They started out in Providence. I believe they're getting ready to expand for a second cohort. And by serving as the backbone, they've really set up the framework, and they've facilitated the work in the beginning, but eventually started handing over ownership and empowering the local partners to carry the work forward. So the state provides plenty of training opportunities and technical assistance. The state actively seeks input and recommendations from local partners, and they empower locals with tools for self-advocacy and sustainability. And they also bridge state funding sources for local initiatives. A couple more quick examples in Utah and Kansas. In Utah, there's a teen health coalition in Salt Lake City, and in Kansas, there's a reproductive health coalition in Wichita. And both of these are examples in which state Title V directors are actively involved in connecting local teams with resources. Some of those resources include collective impact training, leadership training, connecting their teams with state data and epidemiologists, and aligning resources. I also wanted to share an example of a partnership in progress, knowing that sometimes it's hard to see an endpoint and figure out how to get there, and it's nice to see an example of some place that's working on it and not quite arrived yet. So in Tulsa, Oklahoma, there's a family resource coalition, and the local partners tried for more than 6 months to get a phone call with state partners. I'm not really sure where the miscommunication or the barrier was, so we don't know if maybe they were trying to reach the wrong person, or just honestly it was an issue where calendars just weren't aligning for that long. But either way, it took a very long time to actually connect. But after a rocky start, the state partner has been really responsive, and they've been involved in the coalition. And now they are building their relationship and modifying their processes of communication and involvement as they go, and learning what fits best for both levels. So here are some things that some local health departments identified as barriers to partnership. The first one is accessibility and responsiveness of state partners. Like I shared in that previous example, sometimes local health departments don't know who to reach out to, or they just can't get a hold of someone. Their calendar is so booked. So accessibility and responsiveness is a huge barrier. Secondly, understanding why partnering matters. So what's the benefit to the local health department for partnering? And I love what Karen had to say about this. Sometimes it's it's all about communication and language and really putting it into terms that make sense for your partners. So articulating how the local work aligns with state priorities. Visibility of state priorities is also a barrier. Oftentimes we work with local health departments who don't know where to find their national performance measures for their state or their state identified priorities. They're not familiar with that. I think I already mentioned knowing who to connect with, and then also staff turnover, and this is on both sides. So maybe there's a contact at the local health department who is communicating regularly with a state partner, but then one of them changes positions. There needs to be some sort of sustainability plan in place, so someone else should be aware on each level of the partnership and the relationships and how to hand that off if transition is going to occur. So we know that red tape exists at every level, and systems were not set up to work very well together, so at the state and local level. Here are some actionable steps that can be taken toward partnering with the local health departments. Be open to and intentional about building relationships for the long term. Familiarize yourselves with the structure and processes within the local health department and respect those. Connect the dots, and this is referring to what I was mentioning on the last slide, but explaining why partnering is mutually beneficial. Ask how you can support local partners. Sometimes we put a lot of emphasis on the local partners reaching out to the state to make that connection, to talk about what they're doing locally and to ask for assistance, but it would say a lot if their state partners reached out to them first and asked how they can support their local partners. And finally, broadcast the successes and increase the visibility of alignment, whether that's through print or electronic media, just getting the word out, making it more visible to the public that partnership is happening. So, and I wanted to end, of course, with another image from nature, because I think hiking is a perfect analogy for this type of partnership. You have to prepare for your journey. So what's in your pack? Do you have knowledge, tools? Do you have the right contacts? And hiking can also be an uphill climb, much like partnering. But it can also be enjoyable and worth the effort, especially if it pays off for your community members and your state residents. Thank you very much. So it looks like there are some comments in the chat box here. Okay, boundaries, yes, boundaries are important. Okay, are there any questions on my slides? Okay, I will hand it off to the next presenter.
Wonderful. Thank you so much. Good afternoon, everyone. My name is Abby Charles, and I work with the Institute for Public Health Innovation. And I'm excited today to talk about how we can partner to engage community health workers beyond Title V programs and the way that you presently potentially engage community health workers through home visiting, thinking about how to collaborate to integrate more CHWs into maternal and child health programs through collaboration and partnership. So just a little bit about us. I hope today to just give a little brief background about who we are at the Institute for Public Health Innovation and the work that we do in DC, Maryland, and Virginia. Describe a little bit about the role that community health workers play in maternal and child health programs, and discuss some strategies to collaborate to increase the use of community health workers. So IPHI, we're the Public Health Institute for DC, Maryland, and Virginia. So we are a regional public health institute. We are part of the National Network of Public Health Institutes. There are about 40 public health institutes nationally. We aim to build partnerships across sectors and cultivate innovative solutions to improve health and well-being for all people and communities throughout DC, Maryland, and Virginia, particularly those most affected by health inequities. Some of our work, we house the Center for the Community Health Workforce, which is our center for the practice, technical assistance, research, and regional policy activities as related to advancing workforce standards, solidifying the job classifications, etc., for community health workers, increasing awareness of the role of community health workers among health professionals, and trying to create a more sustainable financing for community health workers across our region. But a large part of our role is facilitating coordination, not just in each state, but across the region to ensure that we're really being very strategic as we advance community health worker workforce strategies in our region. So some of our work, we train community health workers. We've trained about 500 community health workers in our, can everybody hear me? We've trained about 500 community health workers national in our region, in DC, Maryland, and Virginia. And we have, we also employ community health workers. So presently we've designed, developed, presently have about 10 community health worker projects that we are implementing across the DC, Maryland, and Virginia area, and we employ community health workers who we integrate at different settings, managed care organizations, hospitals, community-based organizations, health departments, FQHCs, free clinics, to better facilitate access to care and linkage to care. And each program looks different depending on the needs of the program. And we also work very closely to help develop state-level community health worker policy. At the core of this work for us, community health workers, we see the employment of peers, of community members to work in health as a key economic opportunity. So as we're thinking about the work that we're doing in our maternal and child health programs, thinking about how do we advance the economic health of the people we're working with. And one of those key strategies is to ensure that we have community members becoming community health workers and entering into the health system as workers. So I've been talking about community health workers a lot. I'm sure many of you on this webinar are aware of who community health workers are, but just a summary, a community health worker is a frontline public health worker who is a trusted member of and or has an unusually close understanding of the community served. This is a trusting relationship, and that trusting relationship enables those workers to serve as liaisons between the health and social service community to better facilitate access to services and improve the quality and cultural competence of service delivery. So community health workers are essentially members of the community who are doing this work. There are many titles that community health workers go by. Some common titles include health coaches, patient navigators, promotoras, lay health promoters or advisors, community health advocates, home visitors are sometimes community health workers, tribal health leaders, outreach counselors. So there's so many different titles that fall under this role. The community health workers work in all geographic settings, rural, urban, and metropolitan areas. Their roles vary depending on their locale or cultural setting. They're most often found working in communities where people may have limited resources, lack access to quality health care, lack the means to pay for health care, may not speak English fluently, or have cultural beliefs, values, and behaviors that are different from those of the dominant Western healthcare system. Community health workers, their expertise is based on shared life experience and often the culture, community, and health of the people served. They sometimes relate to community members as peers rather than purely as clients or patients. They rely on relationships and trust more than clinical expertise, sorry. They do not provide clinical care. They generally don't hold a professional license, and they can achieve certain results that other professionals cannot. Across the country, community health workers are working as part of community-based or healthcare teams. They provide family-centered support. They meet with families in their homes, in clinics, or in community settings. They're connecting families to needed care and community resources. They are advocating for individuals and community health needs. They're providing informal counseling and social support. They're collecting much needed qualitative and quantitative data in homes and in our communities. And they're providing basic services such as first aid and blood pressure screening as well. Now, in talking about what community health workers are not, they are not social workers. They're not public health nurses. They are not nurses' aides. They're not home health aides. And they generally do not have another professional license, although many community health workers do. And community health workers operate at this intersection of community and health and social services, right? So many patients feel overwhelmed by the complexity of our health systems, and community health workers offer a way to address that overwhelm and help people better navigate these systems of care. Now, in maternal and child health care, community health workers are educating women about breastfeeding, childbirth, providing safe sleep information, injury prevention, and other developmentally appropriate topics. They're providing referrals and connecting women and families with local health and human services. They're helping individuals understand and adhere to provider recommendations. They're screening for infant and other toddler developmental delays, prenatal and postnatal depression, and supporting people with access to care. Now, in our work, we presently are not involved in maternal and child health programs, but we work very closely with some maternal and child health programs in Richmond and in Virginia, where as part of our community health worker consortium in Virginia, we work closely with the Home Visiting Consortium, so the Consortium of Home Visitors in Virginia, as well as we have community health workers who work in maternal and child health who are part of the Community Health Worker Association. And one of the things that I've noticed in our work is that there is rarely cross-training of community health workers to better understand how they can screen and support persons who are, mothers in homes when they are not funded through a maternal and child health program. So we're missing an opportunity to capitalize on people who are in communities when they're not funded through maternal and child health programs to better reach more and more families with information, with screening, with assessment. So, certification, I'm going to scroll through really quickly. These are just different models of care that community health workers can play, from being members of care delivery teams to providing health education, outreach, and community organizing. But certification is moving forward across the country, and in many states, we're seeing that there's efforts to standardize training and certification for community health workers. What role, and as you're thinking about partnerships to engage community health workers, are you at the table in conversations about certification? Are you at the table as you're thinking about how to enhance the training that community health workers are receiving to make sure that they are receiving core concepts in maternal and child health, key things to be screening for in homes or assessing in homes to ensure that persons are effectively connected to resources to support their mothers and children? So as you're thinking about developing partnerships, it's key to understand what does the CHW workforce look like in your state or in your community? Where do community health workers exist? What communities do they work with? What work do they perform? As you think about training, identify opportunities to integrate maternal and child concepts into CHW training and certification at community colleges, at community organizations, at managed care organizations. Anyone who's training CHWs, there's also continuing education. Is there an opportunity to have a specialty certification in maternal and child health, or early childhood education, or breastfeeding that CHWs can get to further enhance the reach of your work? Inform and educate healthcare providers, social workers, clinic staff, and other healthcare team members about community health worker roles. So CHWs need training, but other health team members, other social services members need to understand that CHWs play a valuable role in this system. Invite community health worker networks to MCH meetings, and you attend meetings of community health workers, right? So go to conferences, ensure that maternal and child health is a priority on community health worker conferences as well. Cross-train community health workers working in other health and social service areas. Connect to the community health worker workforce development efforts in your state. So if you're presently working with home visitors, and if some of those home visitors are community health workers, I know that's happening in many states such as Massachusetts, Arizona, and others, in Virginia as well. How are home visitors coordinated with community health workers? Ensure that community health workers are integrated into your teams to provide maternal and child health services in community. Integrate CHW certification efforts with home visitation programs, and recognize that your partnerships are key. And as it relates to referrals, ensure that you can partner with other programs that integrate community health workers so that there's bidirectional referrals. So a community health worker who's working in healthy housing, we want to make sure that they are screening and assessing for any signs of a need for a referral to a maternal and child health program, and that they are aware of how to facilitate that. This is just Healthy Families Richmond, which I know is a program that integrates community health workers with nurses in their home visitation program. They are a part of our Community Health Worker Collaborative for Virginia. So as you're thinking of this work, definitely reach out to them. And this was just a great resource as well, on how to utilize community health workers to improve access to care for maternal and child health populations. So definitely check that out for some case studies about how CHWs are presently being integrated into Title V programs. And I'll end there because I know I'm at time.
Wonderful. Thank you so much, Abby. I think you left us with a lot of next steps and thoughts of moving this work forward, so thanks so much. So now we'll move to our final speaker. So at the foundation of maternal and child health programs is the stakeholders who are served by various programming. So with that being said, we're extremely excited to have a wonderful family leader speak on our webinar today to discuss how maternal and child health programs can strive to include families as active partners in decision making. With that, please welcome Donna Yadrich. Donna will reference the 4 levels of family engagement in Title V MCH and Children Use Special Healthcare Needs programs, which you can download from the file pod in the middle right of the screen. So with that, I will go ahead and turn it over to you, Donna.
Okay, thank you so much. This has been such a wonderful webinar so far. The discussion from Karen to Kara to Abby totally just opened up the pathway for me to talk about our experience. In Kansas, we have an amazing Title V director, Rachel Sisson, and Special Healthcare Needs program director, Heather Smith, who really have integrated consumer and family engagement across MCH domains. And Rachel was acknowledged nationally for her excellence in MCH leadership, and Heather also as an emerging leader.
when we talk about MCH leaders, MCHB defines it as people from a variety of disciplinary backgrounds, public health, pediatrics, nursing, psychology, social work, family, and self-advocacy. And one thing that I'd like to mention is when you're talking about pediatrics, nursing, psychology, those positions, and it was mentioned by Karen, the investment, the time investment of these professionals. They have to understand clearly what it is they're doing, what they're aiming to do if they're going to invest their time and energy. There also needs to be consideration, as Karen mentioned, maybe shared funding, but we need to recognize that is the case as well with family and self-advocates if they're part of the MCH leadership. And HRSA also has that little circle-y, target-y looking bullseye thing with self, others, and wider community. Learn about yourself, become competent, become aware of what you understand and where you need to stretch, and then see how you can translate that to help others, and then with the wider community. And when you look at AMCHIP's levels of family engagement, I really liked the HRSA self is kind of input. It's the lowest level, and AMCHIP came up with these 4 levels because they conducted a very comprehensive Title V directors survey about how they worked with families and in what parts of the MCH domains. And of course, children with use of special health care needs had the deepest family engagement. But input is the very lowest level, and it is evaluating what we have done to somebody. So they really didn't have input in what was going on, but they did a satisfaction survey, and that's kind of used to inform services in the future. The second is partnership, and that's where they have, maybe they've helped you a little bit, share their experience, their story, and have worked on trying to improve the survey, the satisfaction survey, or provide additional input on the way the needs assessment is done. Service provision is where the families have started helping others with similar needs. They are confident enough to start sharing the knowledge to empower others. So in the HRSA target thing, they're now in that second gray ring. And then the final is policy level leadership. And that's where the family leaders are actually saying, this is what the need is, how we need to get there, how we should measure it, what's our level of involvement. So that is the highest level that we should strive for in public health. Every single project doesn't need all 4 levels all the time, but we should try to embed a culture of family engagement. This is my journey, and I have a little red line under the second bullet. My daughter Audrey Grace was 14 when we learned of this world, and she joined the Special Health Care Needs Youth Advisory Council, and then the next year she died, and I felt compelled to finish the work she started and joined the Special Health Care Needs Family Advisory Council in Kansas. And then the next year, our state supported me attending, at that time it was called the Family Scholar Program at AMCHIP, where I became aware and started increasing proficiency in MCH competencies. I was the AMCHIP family delegate for 5 years, and our Title V director and special health care needs director have really worked hard to integrate families as stakeholders in the needs assessment, and they really do a tremendous outreach for conducting on-site need assessments. We proliferate their surveys for need assessments and for critiquing the block grant. They've taught us how to review the block grant, how to help other family members learn how to review the block grant. We've participated, I've been for 4 or 5 years in the HRSA block grant reviews, and our other colleagues are starting to do the same. And then I began serving on the Kansas MCH Council. And we started, family wanted to know what was going on with all the money in the state that comes to MCH and special health care needs. So we started reviewing the aid to local grants. And so we started really getting an understanding of what the different communities were doing. And then we even asked our state to let us know what they did with the money that was awarded for a specific purpose. And earlier, I think it was Kara who mentioned aligning the needs, the national performance measures, the state performance measures, and getting the word out to the local communities. Our grant applications have our performance measures in them, and each person applying has to state how they're going to support those outcome measures. And then we've asked for an annual report now for those who were funded to let us know where they rated on doing what they said they were going to do with the money to advance our outcomes. So I'm doing other stuff, but I was also invited to participate in the infant mortality coin and the PRAM steering committee. We've started a mentor alumni program because it was Abby who talked about continuity, and you have to have continuity planning when you're talking about family engagement. If the same old people like me are doing stuff, that's not good. We need lots of new families all the time, keep replenishing. And so we've started in Kansas a mentor alumni program that now kind of helps the Family Advisory Council. And we also started a supporting peer network called Supporting You, which is it's emotional support for it's intended, the vision is families all across MCH domains. But we're starting with deaf, blind, and special health care needs as we launched just now. The Maternal and Child Health Council in Kansas is a statewide initiative, and it has ways to get all the local partners in the room and discussing what are our initiatives, how we're doing on our outcomes, and what we need to do to move forward to advance our Title V programs. And right now, it was started as a panel before that became the Maternal and Child Health Council, and right now there are 42 members, and plus Title V staff and coordination. But it gets everybody in the room regularly to go over all of our needs and our goals and where we are and how we can get there. So it's the American Academy of Pediatrics folks are in there. Our teaching universities are in there. Our departments for aging and disability, March of Dimes, just tons of people. Head Start. And 4 out of 6 domains have family representation. And for us to have true embedded engagement, it takes a while to get family members up to that level to be able to expand across MCH domains, but it's already having some really great impact. Karen brought up, everyone's talked about relationships and engagement. One of the biggest challenges across MCH getting family engagement is most of the concerns are transient or temporary gestation, adolescence. We expect there's a start and a stop to those. Whereas with special health care needs, it's very chronic and ongoing. You're not going to cure something and move on typically. The other thing is we tend to recruit families that are within, here's my air quotes, the system, who are receiving either the recipients of public insurance or have been provided direct services from these programs. And it's important to get everyone at the table and go to other people's table, as it was said today. So people with private insurance are the majority of healthcare consumers in the United States, so we really have to get them at the table. Our state does provide, so they've taken it from it's complicated to in a relationship. It's a long-term nurtured relationship that requires ongoing training and support with the Title V staff have to be trained on how to engage families in an authentic way, and local health partners need to as well. There also needs to be consideration or compensation to these family members, and I think it should be probably according to the level of participation. If it's basic input, not as much as level 4. But in Kansas, we offer daycare reimbursement, we offer stipends, and then they support other things like conference registration fees, travel reimbursements, and they even will provide training. Our Kansas Maternal and Child Health Council members, family members can do the same thing staff can, like the mental health first aid certification. PRAMS is a good example. I was on the steering committee for PRAMS. We initiated it in Kansas in 2017 was our first year. And if you look at what the CDC said and what other people say, you know, it's that the MCH's role is to get the state and feds to monitor pregnancy stuff. And when I was sitting there as a family member on the steering committee, I said, that's cool, but you want to develop a relationship, so you've got to tell people why it matters to them. And so our PRAMS folks came up with, it allows you to help future moms tell the story of your pregnancy. It supports pregnant, healthy women. And it gathers new data to build programs to help other people. We're trying to whet their appetite to get them to want to become more and more engaged. And we always keep the invitation open. If you want to learn more, if you want to participate at a deeper level, you know, get in touch. Our Maternal and Child Health Council, we trained, we had family engagement training for everybody, and then reinforcement activities along the way. Here was an example. What will you do? We asked every single partner at the table, what are you going to do? And PRAMS did. They initially had said they were going to choose the gift, the incentive to do the survey, and ended up doing it, asking the Becoming a Mom participants to vote on different incentives. So our survey for PRAMS became Share Your Story. We invited them to the table to share their story. The last point I want to mention at our last Maternal and Child Health Council meeting, one key question is a new initiative with March of Dimes. Would you like to become pregnant in the next year? And as a family member sitting there, I said, why are we asking women only? What are you doing with adolescent health and young men? How are how are the people who might want to understand what pregnancy could do to somebody's blood pressure involved in this conversation? And so, that's just something a family member can add that isn't top of mind sometimes to the people who are, on the ground and deep in their performance measures. Here are some totally tremendous resources. The Kansas Maternal and Child Health Council's website has a lot of, all their notes are out there. The family membership application is out there. I would be happy to answer any questions or help in any way, as well as I know Heather Smith from Special Healthcare Needs and Rachel Sisson, our Title V director, would be happy to help. We used Heather's program was modeled for engaging families, was expanded and rolled out across MCH. And then Michelle Jarvis at AmChip. AmChip is such an inclusive and diverse trainer of MCH leadership, and Michelle Jarvis is a tremendous resource as well. This is why I'm here today. Audrey Spirit, my beautiful daughter Audrey, thank you all very, very much, and let me know if I can help.
Wonderful. Thank you so much, Donna. That was a really great closing culmination of our presentations today. And thank you to everyone who presented today for sharing your knowledge and expertise with everyone who's in the webinar. We will continue to build on the valuable information that everyone shared as we progress through this webinar series. So before we jump into our closing activity, we'd like to go ahead and open it up for any questions you may have for any of our presenters. And let me just remind you to use the chat box feature on the bottom right-hand side of your screen, or you can unmute your line by pressing *6. And while you're entering your questions, we did get a question in the chat box after Abby's presentation. So there was a question about where would one recruit community health workers in a rural area. And Abby responded that depending on your state, there may be a community health worker network that already exists. In the case that there is not that network, you can recruit natural community leaders who can be trained as community health workers. And Abby also mentioned, as always, feel free to connect with her afterwards for any resources on recruiting and training community health workers. I think that that goes for all of our speakers. Their contact information is in the webinar agenda and bios document, and I'm sure that they'd be happy to hear from you and answer any questions you may have. So we have a few more minutes for questions to roll in. Does anyone have any questions they'd like to present orally instead of typing into the chat box? Just a reminder that you will have to press *6 to unmute yourself. All right, well, I take it that everyone is just furiously taking notes and downloading the attachments we have in the file pod, so in order to ensure that you're doing some good follow-up. So with that, I guess we will go ahead and turn it over for our skills building activity. And so, Steve, I will turn it over to you.
This is just a great set of partners. And I want to encourage all of the presenters to stick around and engage in the activity with us. So this is what I was thinking we would do, is we would use the chat box to, across all 87 attendees right now, think about some interview questions that you might ask a partner that you want to have a better relationship with. And I thought we would follow the three partner types that we just learned from today. So we'll do questions for your local public health partner, and then we'll do questions for your community health worker partner, and then we'll do questions for your family leader partner. The idea for this is based on an experience I had last year in Kentucky. The Workforce Development Center, of which I'm a part, helped Kentucky do a strategic plan for their children and youth with special health care needs folks. They actually invited some partners to their session, and it actually included, I think, all three of these partners and probably some other ones too. They had folks from AAP and some other folks, but they had those partners in the room, and we said, you know what? We want to do some partner interviews, and you have the partners right here. So we spent about 15 minutes, and we developed sort of an interview guide. Then we broke into groups, and in real time, we interviewed the family leader and the local public health person and the community health worker and the others. So we're going to design right now a specific to you, and hopefully it'll wind up being general for our whole group of 80 people, interview guide for each of those folks. So let's start with your local public health rep. I think there's some clues in what Kara said to tell you what a local public health partner might want you to ask. And you probably have, you're probably curious about something. And so what's a question that you might ask your local public health partner that would do all the things that you want to do in a partnership, which is to say, understand their perspective, be at their table, understand where their energy and passion is, what their goals are, what their hopes and dreams are, what they need from you, all of those sort of things. So go ahead and start typing a curious question for your, and I think specifically to you, what would you want to ask a local public health partner that you have in your state? Kara's helping you out. I've got one based on a question that was in the chat box. Are you working with community health workers in a way that would be helpful for me to know? So Kara's got, what are you working on that you're most excited about? That's such a great question. Shirley's got, how would you like to see local family members' lives improve? That's a great one for getting your partner's dreams out on the table. What do you want to get out of our partnership that makes it beneficial for you? Absolutely. Donna's question is, what could I do that you would find most useful? That's actually a super important question if you're a state person talking to a local person, because there's probably a lot of things you can do to smooth the road for your locals. Kara's got another one. What are some areas that your community has identified as priorities, but that you're not working on yet? So that question's getting at, do you have priorities that you just haven't found the resources or the traction to work on? And the reason you want to know that is because then you're going to follow up with, and how can I help you? How can I assist you in getting started? How can I get you plugged into resources that are available at the state? Do you have a training need that I can fulfill? Stacy's got a great one. Stacy Collins says, what can we do to make this a truly equitable partnership? And there's a clue in what Kara said about what a worry might be for your local partner. And that is, I'm just the local, you're the state. Am I safe? Am I safe working with you, or is there a way in which I could expose myself to some danger by if I reveal something to you at the state, and then I wind up getting in trouble with the state because of that? All right, that looks like a really good list. I think the theme here is to get that local partner talking about their own needs, and especially these are quite appreciative. These are very focused on the positive, and that's a really good approach. Those questions are about, what are you energetic about? What's on your list that I can help you do? What are your goals? Where do your goals maybe overlap with my goals? The point of this kind of approach of actually doing an interview is not just to get the information, but to establish that you're interested in the other person. That builds trust. And think about the sort of dating analogy that Donna threw out there. The dating analogy is, I'm trying to understand you. I'm trying to get to know you better. And let's establish some common ground. Your partners want to know that you're interested in them. Your partners want to know that you get them. Down the road, they want to know that you're going to deliver on your commitment. If it's an initial interview, they want to know that you're committed and that you're listening. People want, if you think about Donna's, well, I guess we're going to go to community health workers next, but think about Donna's message that she just left us with. People want to tell their story. So part of the purpose of the interview is, tell me your story and I'm going to listen to it. So community health worker, what do you want to ask your community health worker that establishes some common ground and builds some trust? And Abby's going to help us. You might think about a community health worker person. You might think about a community health worker representative, maybe someone at the Coalition for Community Health Workers. Ann Buss was listening very carefully to what Abby said, and the clue was community health workers are in the community and they know what's going on in the community. So yeah, what needs do you see in your community is a great question for your community health workers. Sarah wants to know about barriers that clients are facing. The follow-up to that, of course, is going to be, how can we work together to knock some of those barriers down? Susan Colburn was listening carefully because Abby suggested to us, your community health workers are hungry for more training. So what type of training can we provide for you? What support do you need to get training? What support do you need in reaching the MCH population that the state's interested in? What training's available to you right now, and maybe so I can understand it and maybe help supplement that. Donna says, what's the biggest opportunity? What are the biggest opportunities? Where can we scale you up? So I love that question because it's about bright spots. It's about underlying that question is the question, what's working really well that we can do some more? What's working really well that we can study and spread? Kara's got a couple of really good examples here that again come out of what Abby suggested to us. She wanted to get asked about salaries, funding for professional development. Abby told us one of the goals for community health workers and people working in that system is not just to do information, but to be an intervention on economics at the local level. So ask about that by all means. Yeah, what facilitates client success in your community, Karen? That's a great question. The book Switch suggests that you should look for bright spots. So ask about it. Ask about who's doing really well in your community that we can study and try to spread that notion. All right, those look really good. It looks like we've got time to do one more chat for family engagement. So think about a family person, a family leader, family representative that you want to partner with for a specific thing in your state. What do you want to ask them? And there's a lot of hints in what Donna said that suggest to us what they want to be asked. Yeah. April, I think that comes through every time I hear Donna speak. Every time I hear Donna speak, it's really clear. Tell me your story is really a good question. Why does this matter to you? Where is your passion and your energy? The tell me your story is, where did your energy come from? Tell me your dreams is the tell me where your energy is going forward. If you, if you study the tool called appreciative inquiry, it's driven by those two questions. Yeah, Kara, that's a great question probably for all three of these conversations. What's your role? How do you see my role, and how do you see your role? I thought about that. I thought about that with the three non-overlapping circles with community health workers in the middle and the community way over on the left and Title V way over on the right. The suggestion there is we really need each other to make that connection. Karen, how did we do? Are we hitting your principles in the questions that you see in the chat box? I feel like we are doing pretty well on it. Seeking to understand. All right, I hope that you will send your colleagues to this webinar, grab this information out of the chat, and consider calling the Workforce Development Center about further tools. We'd be glad to put you in the way of additional tools to help you uncover perspectives. Really good stuff. Loved the presentations, and thank you all for contributing. Thank you.
Great. Thanks so much, Steve, for leading us in that great activity. We'll follow up with all of the materials in a few days or so, and we'll be sure to type up these questions in the categories that they were presented. So thank you again to all of our presenters and all of the participants for being on the call today. We hope that you found this to be value added for your work and that you'll share the information with your colleagues. As Becky mentioned earlier, this webinar was recorded, and the link to the recording, as well as slides and resources, will be posted to the AMCHIP website in the next week, and you'll get all of those links in a post-webinar email. Please also do complete the brief evaluation that will pop up on our screen shortly. You will also receive a link after this webinar. So we are closing out right on the dot at 3:30. Thank you all so very much, and we hope you have a great rest of the day and happy holidays.